So cryoablation, freezing and killing, cryoablation, has been performed in this country for a very long time. But relatively recently, we have started ablating tumors of the breast. The first study really that became sort of well-read was the American College of Surgical Oncologists. Preliminary data there showed that yes, indeed, they were killing the cancer when they took out the area 3 months later. So the ICE3 trial is probably the latest trial looking at the treatment of small breast cancers. And the goal was to look at 200 women following treatment with cryoablation to make sure that they didn't have recurrent tumor in that area. We've studied small invasive ductal cancer, no pre-invasive tumor around that. They have to be easily visible on ultrasound so that we can literally spear the cancer with the probe, or the tumor with the probe, and grow the ice ball around it as we're watching real time. So we can assure ourselves we've killed the tumor and we have a clean area all around it of frozen normal tissue, so we have a margin. So they ended up with 194 patients, which is a significant number of women. We now have 3-year follow-up data on those patients, and it is extremely encouraging. We have a failure rate, or a reoccurrence of tumor rate in the same site, of 2%, which is actually a lot better than surgery, than lumpectomy. Because we're choosing these cancers very carefully, partly, but we know it's as good as surgery for the treatment of small breast cancers. So basically we perform this procedure in the same room that we perform ultrasound-guided needle biopsies of the breast. We use local anesthetic. It takes us some time to evaluate the tumor and see which direction we're coming, because we never want to point at the chest wall. We always want to come parallel with our probe. So positioning the patient, who's now lying on the ultrasound table, and then evaluation with ultrasound, so size of the tumor, where it is, how I'm going to approach it, from which angle. And we like to put our probe in along the greatest diameter of the tumor, because we can create an oval ice ball, which is sort of oval and parallel to the needle, or the probe, right? And then we'll be able to create a balloon that has a significant thickness that we can encompass the whole tumor in all directions. Once the probe is positioned and we know how far past the lesion we need to go to encompass the whole tumor, we then start the freeze process. And once the freezing is started, everyone can relax, because the probe is now fixed. It sort of cleaves to the tumor and to the breast tissue, so it can't move at that stage. And then we do 2 freezes with a thaw in between. So we freeze anywhere between 6 minutes to 10 minutes, depending on the size of the tumor, and then we thaw for 10 minutes, and then we freeze again for the same amount of time. During that time, we're watching the ice ball grow under ultrasound, so we actually see it engulf the tumor. And the idea is to create at least 1 centimeter of dead tissue around the tumor. So we get a margin that way, which is what surgery we aim to get. And actually, I think we get a bigger margin maybe in a lot of these tiny tumors than the surgeons even do, which could be why the recurrence rate is low. So the most common question that I'm asked is it going to hurt? And the nice thing is that with local anesthetic, it's not going to hurt any more than a biopsy. And actually, the patient told us this morning that it didn't even hurt as much as the biopsy, because as the ice ball grows, it actually has an anesthetic effect. The cold anesthetizes the tissue. So we need very little local anesthetic just for insertion of the probe. And then after that time, the ice ball just causes the whole area to sort of be numb. And at the end of the procedure, they can feel this big cold ice ball in there, which will be significantly larger than the original tumor. And then that melts gradually over the next half an hour or so. And the patient will then have a lump that they can feel there. And we warn them, you're going to have a much bigger lump. You may not have felt your original tumor, but you're going to have a bigger lump now, because we've created a much bigger ice ball. If it's very close to the skin, we have to protect the skin with warm saline and warm compresses on top to make sure we don't freeze the skin. So when I started doing it, I was rather insistent that we had at least 5 millimeters of distance between the skin and the tumor, because we knew we could dissect the skin off the tumor by injecting saline. I started off with just injecting saline, and then we started injecting warm saline, which gave us a little bit more protection towards the skin. I like to do a baseline 3 months. There's no point really in imaging before that, because you want the area of cryoablation to be clearly seen on ultrasound and mammogram, and it usually takes about 3 months for it to mature so that you can actually see it. Definitely in a fatty breast, you'll see the rim around the clip on the mammogram. On ultrasound, it's somewhat variable, but normally by 3 months you can see, the outline of the cryoablated area, and you can evaluate for blood flow in and around that cryoablated area. So you've got a good baseline at 3 months. And then after that, I try and stick pretty much to what the standard of care follow-up has been for a lumpectomy and radiation. So normally we image the area every 6 months for 2 years, and then after that I'll put them back to annual screening. So tumors are made up of the tumor cells, the cancer cells, if you like, and then outside, so a cancer has a volume, right? And outside of those actual cancer cells with the cancer DNA, you've got an intercellular space, which is mainly water. So when we insert the probe, and as you grow the ice ball, the first thing that happens is that extracellular water starts to freeze. And it freezes first before the internal part of the cell freezes, because the osmolality is different. So you get the ice starts to grow in the extracellular space, and you get crystals and all the rest of it. And then eventually the cold will start to affect the cells. But we're discovering that the thaw process is very important, because when the tissue thaws, the extracellular cold tissue is now drawn into the cell, because the osmolality changes, and it's drawn into the cell swells and disrupts the membrane of the cell. So effectively you kill the cell, right? And the organelles inside of the cell, the little powerhouse that makes every cell work, etc., all of those things will then die, because now that cell's cold and swollen and the membrane's gone, so we killed the cell. And of course other things are happening too. You're interrupting the blood flow, so again, if you don't have blood flow for 3 minutes, you're effectively killing the tumor too, even without the cold. There's something called delayed apoptosis, which is death of the cell, which will happen probably within 5 millimeters of the external edge. So you get an even extra effect there. And that's all good, because that is recognized by the body, and you get the inflammatory reaction, and that's how it's, that dead tissue is recognized and eventually sort of mopped up by your own body. The thaw is very important, because you want that cold fluid to be drawn into the cell now, and then you want ice crystals inside the cell. The second freeze effectively enlarges the balloon a little bit further, because frozen tissue transmits the cold quicker. So the second freeze is hopefully to grow that ice ball even a little bit bigger. So you might get that extra 1 centimeter around the tumor. We've created this big ice ball. The body reacts to any form of injury. So we've created an ice ball which kills the tumor and dead fat, right? And the body reacts to that ice ball by inflammation. It sends in cells and new blood vessels and everything to deal with that inflammation. If the tumor has been surgically removed and you're then sterilizing the area with radiation, there isn't really any tumor cell left for the immune system to recognize. But we think that cryoablation, because there are dead cells whose DNA is still recognizable by the patient's immune system. And our immune systems are amazing. I mean, that's why most of us don't get cancer, because a cancer cell is picked up by the patient's immune system and dealt with before it becomes a clinical cancer. So cryoablation seems to be labeling that patient's cancer to that patient's immune system. So it's a tailored vaccination in a way, is the way I explain it, which is very exciting. Patients can have this procedure done in an outpatient setting, so either your surgeon's office or your radiology office, but not in a surgical suite, which is fantastic. We don't have to put the patients to sleep. We don't have to cut the skin and leave them with a scar or stitches, sutures. It's a very quick procedure, depending on the size of the tumor, but most patients, the procedure doesn't take longer than half an hour. And they leave the office with a steri-strip on the skin and they can go back to work. So work and family time is, that they're able to be back very quickly. I have been in breast imaging for, I specialized, I don't want to tell you how long, but at least 30 years. As the only female in my practice, I was given mammography and breast and diagnosis, and after that we started doing needle biopsies, etc., etc. I decided that I really wanted to spend more time doing cryoablation. I think this is an incredibly exciting area to be in, and I have 3 daughters, and I would love to think that if any one of them was unlucky enough to be diagnosed with a cancer, that they could be treated without lumpectomy and radiation and all this stuff. After doing quite a few cases, I realized that, I wanted to do this. So luckily my staff, who had started with me in 2016, they still wanted to help, because not too many people, are aware of this, right? It's the patients that are driving this, and they want to help get the word out there, to women everywhere, that this is an option.